In fact, most of the hostages and POWs I've seen and treated have not had serious mental health problems. They've had a lot of post-traumatic growth. So they've appreciated life in a different way. They've kind of had ongoing relations with their family on an emotional level when they were held by themselves. And they've appreciated life much, much more. Their value structure has changed.
You have found the Thinking Mind podcast.
Today I'm happy to bring you this pre-pandemic conversation with Dr. Walter Busuttil. Dr. Busuttil is currently the medical director of Combat Stress, which is an organization that was specifically set up to deal with mental health problems of military veterans. And he's also the chairman of the United Kingdom Trauma Group and a board member of the United Kingdom Psychological Trauma Society. After graduating from his medical training in Manchester, he spent a lot of time in the Air Force and was involved in the retrieval and the rehabilitation of British hostages in the Beirut hostage crisis, as well as veterans from the First Gulf War. And then later in his career, he set up and led a service to treat post-traumatic stress in survivors of sexual abuse, and then later set up another service, a psychological trauma service for women suffering from complex post-traumatic stress as well as borderline personality disorder. So we had a really fascinating conversation all about how he came over to the UK from Malta by himself in the 80s to do his medical training, his time in the Air Force and dealing with the complexities of trauma in both veterans and civilian populations. We talked a little bit about how the military can give structure and a sense of belonging to people's lives and many other topics. I hope you enjoy. I thought maybe we could start talking a little bit about Combat Stress.
Sure.
And what you guys do, maybe a bit of the history about it.
Okay.
What your role is.
Yeah, so Combat Stress is a charity that looks after veterans with mental health problems. And it was actually started off in 1919. So we're in our centenary year. And the reason why Combat Stress came about as a charity was that after the First World War, there were about 5,000 veterans who were locked up in asylums, and many wives and good women and daughters felt that this was wrong and that the state should look after them properly. So they linked into the suffragette movement, and they also then had backing from royalty at that time. And they set up a series of homes basically to give respite care. But some of these homes actually were residential in terms of long-term residential for veterans who really couldn't do very much for themselves. So they set up mainly a kind of therapeutic milieu with basic crafts. So, there were periods at Combat Stress where people did basket weaving, would you believe, and had farms, had pig farms and planted various crops. And then periodically, as the wars kind of came and went, Combat Stress ramped up its intervention. So there's always been a kind of mental health element to Combat Stress. It was called the Service and Ex-Service Mental Welfare Society. So it was about mental health and welfare.
It's quite telling, isn't it, that it seems the state, both in the UK and from what I can tell in the States, they always seem to come up short when it comes to looking after their veterans once they've come back from a conflict situation, especially in the realm of mental health.
Yes, I mean, certainly this country really has lagged behind. I mean, I would say that in the States, there's the Veterans Association, which was set up after Vietnam. And Vietnam, if you like, was a big turning point for veterans' mental health in America, in that many of the veterans went and campaigned even against the war, but certainly a lot of the reason was that there was no care at all for them. So they were a very angry bunch. And the same thing happened actually in Australia. And Australia sent 60,000 soldiers to Vietnam. And when they came back, Second World War veterans told them they weren't real veterans because they hadn't fought in a real war. In fact, they were the point regiments for the Americans, and they had a lot of casualties, the Australians. And when they marched through Sydney, they were pelted with rotten eggs and tomatoes. So the government then suddenly woke up and took things very seriously. And they did set up one of the best, if you like, or the best mental health services for veterans. And, you know, we've had a long-standing relationship with the veteran services in Australia, but also with other veteran services across the world. Now in Britain, it's reasonable to say that actually the early part of the 2000s, the British NHS wasn't really that interested in veterans, and there was no real policy for veterans other than, and certainly I was told to my face in 2007 when I was appointed medical director here, so that's only 12 and a half years ago, that veterans were just like any other uniformed service. They weren't special, and that they'd get treated in a bog standard NHS service.
And why do you think that was the case?
Well, I think, certainly I was told this by one of the most senior doctors in the NHS. I think they didn't appreciate, and people didn't really understand what serving in the military, and particularly serving in combat, entails. I mean, I served for 16 years in the military. I joined as a medical student. I trained then as a general practitioner doing general duties, so a general duties medical officer. And then I was lucky enough to retrain in psychiatry. So in effect, when you join the military, you give away all your life. You're told where to be, and you're given a uniform, and you have to conform to a hierarchy. And if you're married, if you're allowed to get married, so I had to ask permission from the station commander to get married. If you're a certain age, if you're young, then your wife and children are subjected to the same total institution, which we understand through our psychiatric training. You know, it's all Goffman 1961, and you know, if you need something, you'll ask your sergeant. If you're looking after property, there'll be somebody to help you. And really your life is totally dominated by being efficient and being able to run things properly. So your culture changes in the military. It is a total institution.
It's a completely different way of life.
It is a very organized way of life. And I think it's really great because, you know, I was a Maltese person by myself here in the UK studying medicine, and I found a new family. So I got attached, very attached, and we will understand this through attachment theory. I got attached into the military. And many people who have a primary family that's disrupted, or maybe they've been adopted or abused, or some adverse things have happened in their childhood, they will seek to join the military, and they do have very strong attachments, and find it then extremely difficult when they come to leave.
What were the reasons that you left Malta at such a young age to go to the UK?
So what happened to me in 1977, I finished my A-levels, and the Maltese medical school had a degree that started every 2 years. And I was waiting for the course to start. I'd passed reasonably well, and I would have definitely got a place. And unfortunately, we had this problem with Don Mintoff and the doctors went on strike.
I see.
And effectively, the medical school closed because...
Don Mintoff was the Prime Minister of Malta at the time?
That's right. He was Prime Minister at the time. And I hadn't applied to go to medical school in Malta, but it was intended that I would. So... a friend of mine who also wanted to become a doctor got an application form for the UK, and he said that he would apply. And I said, well, there's no way I'll ever apply to leave Malta. I love Malta too much. And he said, look, I've filled yours in, and will you sign it? And I said, okay, I'll sign it, but I'm certainly not leaving. And then there was one university in Manchester that accepted me. And I told my dad, well, you know, I could either become a footballer or work in a bank, or else go to Manchester and become a doctor. And I know you can't afford it. And he said, no, I'll afford it as long as you go. I said, well, I'll go and have a try. So it was all kind of a bit of a mistake. My friend didn't get in, but he got in the year after me, and he went to Liverpool. So he's a doctor now too. Yeah.
So it must have been quite isolating to be in the UK by oneself.
Yeah, I think at 18, I didn't think I was that young. So, I was fairly resilient. I was certainly keen on sports and I made lots of friends. But I think then what happened was that my dad had a heart attack when I was in my beginning of my third year. And I thought, well, I think if anything really serious happens, like he dies, then I'll have to give up medical school. So I looked around and I found out that I could get a commission with the military. And I was quite interested in joining the military. Certainly the Air Force attracted me more than the Navy or the Army. So I applied and then I eventually got a post as a medical student with the RAF.
Mm-hmm. And like you said, it gave you that sense of structure and family.
Yes, it did.
And helps one feel a bit at home in an alien environment. In a way.
It did to a large extent. But, as a medical student, you behave like a medical student. So, I never cut my hair. I was pretty much looking like a student. Whenever I went to University Air Squadron, the commander said to me, well, you better get a haircut. And I said, well, you're not going to deploy me or anything, so I'll continue to be a student.
Quite rebellious.
So it was quite interesting. Anyway, yes.
Were you ever deployed in the Air Force?
Well, in the Air Force, I served first of all at RAF Waddington, which is in Lincolnshire, and I was one of the last doctors to, if you like, see the Vulcan. Effectively, the Vulcan was a big bomber aeroplane that used to, if you like, fly over Malta when I was a boy, and it was really interesting to be on as a squadron doctor, one of the last doctors ever to serve, and then during that first year I got deployed to the Falklands after the war, so this was 1984, and that was really interesting, and still kind of quite a dangerous zone while I was there, and then in that year as well I went to Ethiopia on the famine relief operation. That was really interesting too. And then at the end of that year, I got posted to Germany, where I spent 2 years plus on a flying station with fast jets, which was really exciting. And then for 18 months, I completed my general practice vocational training at RAF Hospital Vegberg, which is now bulldozed. And then eventually I came back to the UK in 1989, I think, yeah.
So in those places, were you doing mostly general practice rather than psychiatry?
That's right. I was doing general practice. And it was interesting because part of it was occupational health. So, I was a squadron doctor. I had to make sure the pilots, for example, weren't tall enough that they didn't fit in the cockpit. I had to be sure that they were kind of physically fit. So that was really interesting. And then, of course, we had the families there. So I think the population was around 7,500 to 8,000 people on camp, including families and children. And so it was a thriving primary care facility with an occupational health bent. And you could be sent on, if you like, exercise training with the squadron. So it was great fun. It was really quite good.
Mm-hmm. Did you notice any particular psychological problems which are quite common in these pilots and their families?
Yes, I did. I think there were two things. First of all, when the pilots deployed or the squadrons went, the families were kind of left behind, and the wife usually took over what normally the wife and husband used to do together. So things like paying the bills, buying a car, making big decisions would have been done by the wife. And we can see that today, even in myself, because I was used to going away quite often. So today my wife still buys me a car and tells me I need to sign this for the bank or whatever. So, that has remained part of the problem. So there has been a kind of intermittent husband syndrome. In fact, it's a syndrome described in not only people serving in the military and submariners' wives, but also in oil rig workers' wives. This was described in the 60s. And the syndrome, intermittent husband syndrome, comprises three features. One is anxiety, the second one is depression, and the third, of course, is sexual difficulties. And of course, it's only the wife who suffers, which is probably not true. So that was one of the areas. The other area was that fast jet pilots are very macho. It's very manly. They were very young. I mean, there were people in the very early 20s flying £1 million aeroplanes, and they were extremely well trained. But they really didn't want to confess to any kind of stress problems, emotional difficulties. No, but as a squadron doc, I found that if you were in with them, they would tell you about them. So as a GP, I felt I did more good for aircrew than perhaps I did as a consultant psychiatrist, which will come on later, because eventually in my time in the Air Force, I was a community psychiatrist, which served about 6 or 7 fast jet flying stations. So it was really interesting to revisit my experience with fast jet pilots. Yeah.
And I imagine the kind of trauma that is experienced by your average sort of pilot is very different from the kind of trauma that would be experienced by a soldier on the ground.
Yes, I think serving in the Air Force, we had an RAF regiment. I mean, the RAF regiment was designed or is designed to protect military airfields. That's their primary role. And of course, we did have training accidents. So, in peacetime, that would be the primary reason why people would be subjected to traumatic stress or even car crashes, because you've got lots of macho young men who drink a bit more than is good for them because there's an alcohol culture in the military, and who take risks. So those were the primary traumas. But, for aircrew, it was going to be something like an ejection, an emergency ejection, or a crash. And unfortunately, those things do happen. It was interesting. While I was in the Falklands, I was squadron doctor to only 4 Harriers. These were 1 squadron Harriers. And one of my pilot friends, by then, you're integrated in the squadron, had an accident. He flew his aeroplane into a giant petrel, which is a bird that's bigger than an albatross. And he had to eject. And, we were out there, myself and various medics, looking for him in the sea, really. We were driving around, there were speedboats everywhere. And then because the Falklands was such as it was in, I think 1984, I ended up operating or assisting in the operation at the, if you like, MASH hospital we had, which was very ad hoc, and then arranging his medical evacuation back to the UK. So things did happen, and they were, if you like, dangerous. I mean, a military environment is dangerous. We practice in real a real environment, and accidents happen.
Yes.
Yeah.
Did you ever encounter any pilots who were traumatized by using their weapons? So, for example, launching a missile, actually trauma from accomplishing their mission?
Well, I think we kind of need to talk a little bit about what happened then during the Gulf War, the first Gulf War. So I've completed my training in general practice, and really my time was up in the Air Force, and I was offered a more senior role in general practice. And I said, look, I want to turn this down because I want to become a psychiatrist, and would you train me? And eventually they said yes. And I went to a place called RAF Hospital Wroughton, which was near Swindon in Wiltshire. The hospital, unfortunately, now is bulldozed. But we had a very good training system at RAF Hospital Wroughton. So that was the training centre for RAF psychiatry. In all, during the Cold War, so we're still in the Cold War, 1989-ish, we had something like 17 senior psychiatrists and, several juniors, 6 or 7 juniors. And I was lucky enough to get a place. And the first thing that my boss said to me is, he said, look, Walter, I need you to look at this file, and I want you to research what might happen to these people. So the file was about the Beirut hostages, so Terry Waite and John McCarthy and Jackie Mann. And the thing that we were thinking about is that if they were ever released, we would kind of retrieve them and then see what the matter perhaps was with them, and if there was a problem, treat it. So my boss then, who was a wing commander, Gordon Turnbull, he's Professor Turnbull now, was very much into traumatic stress disorders. But the rest of psychiatry in the Air Force was not into traumatic stress. It was really something new coming in the late 80s. The Navy had experience after the Falklands War of 1982 that set up a training center which did rehabilitation for mostly naval personnel and Marines who had fought in the Falklands. But the RAF eventually got a lot more experience in about 1991 with the Gulf War, first Gulf War. So really, before the Gulf War happened, I was doing all this kind of reading about traumatic stress, torture, incarceration, solitary confinement, being taken hostage, the impact of that, and then the impact of coming home. So I read a lot of papers about prisoners of war, and then people who expected them to be dead. So their family, in theory, might go through a whole anticipatory grief reaction. And if that grief completes, then usually what would happen is that person coming back would have great difficulty reintegrating into the family. So I did all that reading. And then we had, I think Gulf War I came before the hostages. And my role then was to set up rehab services for people coming back from the war. My boss, Gordon Turnbull, was sent off to the war. Because I was junior, my war role was back in the UK. I was joined by a retired consultant, John Rollins, who's now deceased. He used to be in the Air Force, and he had set up the Navy psychiatric services following the Falklands War, so the PTSD rehab service. So we set up a brief intervention, lasted about 2 weeks. It comprised 3 main ingredients. The first was psychoeducation in a group. The second was skills training in a group. And the third, at that time, we did trauma-focused therapy in a group. We did exposure in a group, and we had a group therapist to do that. And that worked extremely well, not forgetting that many of these people had been traumatized relatively briefly, because the first Gulf War was fairly brief. But as part of that, we also had pilots who came back into that program. And the aim was, to keep the principles that were set out in the First World War of PI-B. So PI means proximity, intensity, and brevity, with the expectancy that people go back. So back to fight. So the philosophy was that this was going to be a brief intervention, and if you were needed back on active service, you would go back. And for this program, we negotiated with Surgeon General that people would not be medically downgraded if they came to the program, but they would be if they failed it. And nobody failed to go back, as it were, or to go back to a war role if they were required. And the pilots did go back. So they were eremeded back. They had been on bombing runs. They found it difficult. They hadn't managed, if you like, to get over the impact of having to fly very, very low. It was very dangerous flying. And of course, they then went back and they functioned extremely well, and they went back on full operations, and we didn't have any long-term fallout.
Mm-hmm. Do you think they were prepared for what they were actually set out to do, for causing those kinds of levels of destruction?
I think so. I think, when you think about how air operations were kind of performed in the 90s, early 90s, you'd kind of fire your bomb like a slingshot. So you would release it 2 miles away from the place you wanted to drop it on. So and not many aircraft had all this kind of intensive imagery where you could tell exactly where it was falling. So to be honest with you, I think a lot of the issue was not about dropping things, because they were extremely well trained for that. I think a lot of the issue was about receiving AAA, which was the ACAC, as it were, and that was very sporadic, but very accurate as well in some bomb runs. Yeah.
And what was it like working with the hostages from the Beirut hostage crisis?
Yeah, I mean, that was quite interesting. I mean, we had a team, so we had a team that would actually go out and retrieve them, which included a physician. The main thing about being a hostage is, certainly in these circumstances, they were held hostage for many years. Terry Waite, for example, in his book would say he was chained to a radiator for 4 years. We were worried about heavy metals in water and signs of starvation and vitamin deficiency and head injuries because of torture. So, we took a physician with us to retrieve them. And there was a small psychiatric contingent with a consultant psychiatrist, perhaps a junior psychiatrist as well, a couple of nurses. And the aim was to just bring them back to the UK and then have a private reintegration within their family. So we'd met all the families before. I was involved in all three, but not at the same degree. So I wasn't necessarily always on the retrieval party or on the rehab party on the way back. So we kind of mixed and matched. Just as an anecdote, I was at, for one of them, I was at Crammer for the MRC Psych Part 2 exam. If you're a student, psychiatric trainee listening to this, and I told my boss, if there's another hostage that's released, I want to go. I want to be part of the retrieval, and he honored that. He sent a policeman who interrupted the lecture and said, Walter Busuttil, come with us now. And I was whisked away in a police car. And then
it must have felt quite special.
It was quite interesting because the MRC Psych exam was 10 days away, and we expected, this was Terry Waite, we expected Terry Waite to come out the day after we landed in Cyprus. So we'd land in Cyprus and wait for for intelligence effectively to tell us when he was going to be released, and then go over to Syria to retrieve the hostage. And what happened, in fact, is we waited 10 days, and I just got back for my exam, and then I did the exam and passed, which was lucky.
Good job.
Yeah.
I suppose there's a limit to how much you can talk about this, but what was it like for the hostages that were released, do you think?
Yeah, I think, look, they've described quite a lot in their books, and I would really encourage people to read their books because, the theory of having, being taken hostage and ending up, for example, for many years, or being taken prisoner of war, and certainly at combat stress, I've met a lot of POWs over the years, certainly from the Korean War, for example. And then while I was still a junior in the Air Force, we assessed a lot of Far Eastern prisoners of war. These were Second World War veterans held in Japanese POW or concentration camps, really is what they were. And really what struck me was that although the theory was that we expected PTSD, depression, a lot of physical illness, with, for example, the Far Eastern prisoners of war had a lot of parasites and tropical disease still active. We also expected their personality would change from a negative point of view. They'd be very angry and apathetic. We could talk about an apathy syndrome and psychosis as well. If you're held in solitary confinement for more than 3 days, you almost guarantee that you'll start hallucinating. So that's what we expected. In fact, most of the hostages and POWs I've seen and treated have not had serious mental health problems. They've had a lot of post-traumatic growth. So they've appreciated life in a different way. They've kind of had ongoing relations with their family on an emotional level when they were held by themselves. And they've appreciated life much, much more. Their value structure has changed. So actually, did we see a lot of mental illness? The answer is we did not. I think more importantly is that the intervention, which we called at the time psychological debriefing, which is now discredited as an intervention, and we can talk about that perhaps another time. But that was all about getting the hostage to talk a bit about what happened and their emotions, and then to integrate the family. So we did a lot of family work, and there was preparation with the families before the hostages were released. And the aim was that we needed to be sure that the concept of anticipatory grief, which I kind of talked about a little before, was dealt with. So anticipatory grief was described by Lindemann in 1944, so it's not a new thing. And what it's about is that if somebody is sent off to war, or there's news that they've been captured as first missing in action, and then maybe it's known they're a POW, is that the family, and usually the wife, takes over all the operations within the family. And it could be, if there's no news about that individual for many, many months, is that they will start to grieve. And even some families, some wives would grieve the minute the husband goes to war, not expect him to come back, better prepare myself.
And they'd go through the whole grieving process.
And they go through the whole grieving process. So when he does come back, then it's a real effort, and it's sometimes impossible for that person, the husband, to be reintegrated into the family.
Would there be like an unconscious resistance within the family?
Absolutely. There'd be a dynamic in the family that's very difficult to explain, and the individual coming back would feel left out. And maybe the wife would make certain decisions that would make the marriage irretrievable. So she'd go and have affairs, or else she wouldn't care much about the husband and wouldn't care maybe about herself. So, in addition to that process, there are kind of mental health issues with the wife. And then, of course, there is impact on the children as well. So the children will cope as well as the wife does. And that would kind of mean that the wife might get depressed, formally depressed, have anxiety problems or alcohol problems, smoke too much, or else play the field, as it were, and have other relationships. Yeah.
The other idea I've come across relating to soldiers coming back from war is the idea that often these young soldiers, their experience in combat is the most thrilling, exciting, engaging part of their life.
Yes.
And they experience a lot of solidarity with the soldiers that they're with.
Sure.
And so when they return to civilian life, it actually feels like a dumbed-down version of reality.
Yes.
And that this is part of the problem that these soldiers face when it comes to reintegrating in society. I think the book that's been written about this is called Tribe by Sebastian Junger.
Right. Yeah.
He made a documentary about Afghanistan and Iraq.
Right. Yes, I think this is very important. The soldiers will say, combat soldiers will say, it's the rush. And they do get a rush. I mean, there's a lot of kind of literature on this, in that they, you'd think, well, these are people fighting for Queen and country. They're not. They're fighting for their mates, really, for themselves. And the way they're trained is, certainly in the British military, is you fight in very small groups of maybe 6, you know each other extremely well. Your training will weed out the weakest link. The weakest link is not required because that's the weakest link that will get you killed. So these are very closely bonded people. As we said a bit before about culture, they have the same mentality, the same culture, and the same aim. And they will get a high, some of them certainly will say, when they're in combat. And it can be extremely difficult to explain to other people who've not actually been in that situation. And also, when they do come back, they will need to feel alive. So combat is really not good for you. It does cause mental health issues. At the very least, it will cause you to be irritable and angry. Not that you'll have a mental health diagnosis, but for some, it will start to have a mental health effect. At the least would be perhaps an adjustment disorder. But we know from studies done in Iraq and Afghanistan veterans, which were perhaps for the first time studied properly in a British population. All these studies are on the King's website. That's the King's Centre for Military Health Research, KCMHR. Google and have a look. Combat is associated with higher rates of depression, common mental disorder, anxiety, alcohol problems, and, for some, post-traumatic stress as well, and also aggression and violence, domestic violence included. So not everybody's affected. I mean, it's always important to kind of look at the causes of these mental health problems. So, things about lack of support before, during, and after is more likely to cause you post-traumatic stress and other disorders. Big life events when you come back, a dear John from your missus perhaps as well, that doesn't help. And then a dose-response effect. So the more you're exposed and the more horrific it is, the more personal it is, perhaps you identify with a dead body, looks like my mum or something like that, then the more likely it is you will become mentally unwell.
Yeah, because if you go back to older conflicts, like as far as I'm aware, World War I was the first one where some kind of post-combat neuroses was described. And if you watch videos of patients experiencing that, it seems to be a very different phenomenon from the PTSD which we think about today.
Well, actually, if we read the Cunius Papyrus of 1200 BC, that documents what happened to Egyptian soldiers after combat. Their symptoms are fairly similar to symptoms of modern-day soldiers. So, when we look at the history of post-traumatic stress, it's been called many, many names. So, Swiss mercenaries in the, maybe 13th, 14th century, they were described as having various symptoms that were described as nostalgia. That kind of recurred in the American Civil War. Many soldiers towards the end of the war, certainly on the Confederate side, they deserted. When the war isn't going well, you get higher casualty rates for mental health problems. So it's fairly well documented. And then Shakespeare, in King Henry IV, there's a description there from Lady Percy related to Hotspur, her husband, who's been in iron wars, who cries out in his sleep, who's sweating all the time when he's asleep. Mm-hmm. And then we have kind of descriptions with Samuel Pepys, the Great Fire of London, how that affected him and people, which are symptoms of post-traumatic stress. So there's quite a lot. Charles Dickens, Staplehurst railway crash in 1865, and he had to lay there with dead bodies for 2 hours. So it's fairly stereotypical. So there is a stereotype. People do kind of think, well, actually, they were quite different. Disorderly action of the heart was described around even in the First World War. That was kind of a bit different to shell shock, where that was kind of mainly neurological symptoms. People talked about shell shock as being caused by shaking to the base of the brain, and that really is an old term, because that's what Victorian doctors thought was happening, because of course in Victorian times, for the first time they had railways, and for the first time they had rail crashes, and people who appeared to be kind of whose bodies appear to be intact after these rail crashes, but they died, had post-mortem bleeding towards the base of the brain. So when shell shock came along, people thought actually sending off shells and receiving shells could give you shell shock, and there must be a bleed towards the base of the brain. So that's an organic condition. Whereas other people said, no, it's about poor morals, and these people are cowards, let's shoot them. And that's what happened to 267, I think, in the British military in the First World War. And then other people said, no, this is a psychological problem. And Freud was kind of very interested in trauma, and people then started to adopt his theories. And, if you look at Craig Lockhart and Rivers and what he did, he was perhaps the only psychiatrist or psychologist, I think he was a psychiatrist, who actually got people to talk about what happened. And when we look at modern treatment for post-traumatic stress, it's about telling the story in a safe environment and reliving what happened in a safe environment. Mm-hmm. And, historically, in the First World War, they didn't do much of that. So that was really quite important, that people then started to identify this as a psychological illness. But then, of course, we have all this learning and forgetting and relearning. As I said, the Air Force had 17 uniformed senior psychiatrists during the Cold War, and now it's got maybe 3 psychiatrists, and, a lot of expertise has gone. Not saying they're not expert, but there aren't enough, perhaps, of them. After the First World War in 1922, there was a whole kind of movement to discredit the concept of shell shock, and it was discredited. It was a national thing.
What do you think was the motivation for that?
I think a lot of the motivation was, people trying to, if you like, deny there was a national issue with shell shock, and
to deny that war is a serious issue.
To deny war is a serious issue, and it cost money to pay war pensions. I mean, it costs a lot of money to acknowledge actually somebody can't work because of an injury that we've caused him or her to suffer for the country.
So there's a reluctance to admit some of the very serious adverse consequences of government level policy making.
Yes, I think so, and we had this to a degree before or around the time, certainly, of the Iraq and Afghanistan war, where people in the health service here just didn't understand. So they'd forgotten. No one had read military psychiatric texts, and there aren't that many doctors now who serve in the military who know much, or at that time who had become civilians. So the comparison, say at the end of the Second World War, the United States had something like 6,000 psychiatrists in uniform. At the beginning of the Second World War, they had 2 uniformed psychiatrists. So there's a huge boost in knowledge of what's going on. We need to treat these people. But then, come the end of the war, most of those uniformed psychiatrists left. Yeah. So it's just natural,
And getting back to what we talked about at the beginning, it's telling that As it stands, the NHS by itself isn't equipped to deal with the psychological problems that veterans are presenting with.
Well, yes, to a degree. But, the NHS was set up in 1948. And one of the main reasons as to why it was set up is to look after the soldiers coming back from war and people affected in the UK by the bombings. So, in a way, it lost its way a bit. And I think that's quite a relevant issue. And of course, in this country, we have a definite separation of military health versus the NHS. So, of course, in the last 10 to 15 years, that's becoming more blurred, in that now military hospitals have closed. When I joined, we had 8, 9, 10 military hospitals across the UK and abroad. Now really all those hospitals have closed. And the NHS is contracted for beds. And there are wings in some NHS hospitals, say, for the main specialties. So in the military, your main medical problems are going to be orthopedic because of all the training. They're going to be mental health because of all the accidents and going to war. And it's going to be hearing loss because of all the machines we use and aeroplanes and firing of weapons. So those are the three main specialties. Of course, you need anaesthetists as well for intensive care. But really psychiatry, orthopedics, and ENT and anesthesia, those really are the main specialties. But in my time, for example, in Germany and in the UK, we had obstetrics, gynecology. My son was born in a military hospital. We had uniformed obstetrics, we had pediatrics, we had most of pathology. Everything was in uniform. We had a good setup. Yeah.
So, obviously, some of the lack of ability of the NHS to deal with these issues of PTSD in veterans is dealt with by combat stress.
Yes, some is. I think if we look at where the NHS has been with PTSD, so in the military, what I can say is the Navy learnt its lesson after the Falklands War and the hierarchy. So those are officers who are not medical in any way. They signed up to it and they knew they had a serious problem. And then the Air Force signed up to it after 1991, Gulf War I, and the Army kind of a bit later on in the 90s. They recognized it as an issue. But if we look at mental health generally, certainly psychology started to pay a lot of attention in the late 90s, the early 2000s in this country. It became kind of part of the curriculum, not military PTSD, but PTSD. But general psychiatry really has lagged behind dramatically. I mean, Anke Eller's produced a study in relation to GPs who had patients at the traumatic stress clinic at the Maudsley Hospital. So this was a publication published maybe 4 or 5 years ago. And only 3% of GPs were assessed as competent enough to diagnose PTSD. So there's been a lag in terms of the medical doctor profession has lagged behind. And psychiatry, I think, is lagged behind too, because psychiatry in this country really focuses on very difficult risk presentations and psychotic presentations. And really that's where the funding reaches. But there's a big kind of problem in that people, certainly who've served in the military, have been to combat, they're likely, if they are ill, they're likely to be quite ill. And of course, because they're men primarily, they're very macho, they find it very difficult to engage in services that are not run by people who understand the military. So
people with a military background like yourself.
Yes, and really combat stress did find its role. So in 2007, when I joined, the main reason for appointing me as the first full-time doctor ever appointed at combat stress, and we had 3 respite care homes with very little going on in terms of therapy, and I replaced the doctor who visited the centre here in Surrey, Turret House, half a day a week I was full-time. We had half a doctor in the Midlands, another residential centre, and no doctor at all up in Scotland. We had 3 residential centres, 87 beds. And my remit was to set up cutting-edge clinical services, which is what I'd done. I'd left the Air Force 10 years previously. I then worked with adult survivors of abuse for 10 years, setting up services. And really, it was starting from scratch. We had no clinical governance. We had no operations director. We had no structures and no programs.
So what is cutting-edge treatment for PTSD?
Well, cutting edge is looking at the evidence base. So for military-related PTSD, if you go on to the latest NICE guidelines, your trauma-focused therapy ideally should be trauma-focused cognitive behavior therapy. It's superior to EMDR, eye movement desensitization and reprocessing. But of course, you need to use a phasic model. You need to make sure that people are stable enough to tolerate reliving their worst experiences in a therapeutic rapport. And then you need to be sure that they've got the skills to cope. So this is kind of the triphasic model was described a few years ago. And what's important about it is that there is quite a big evidence base for using this tactic, as it were. But look, when you have many numbers, usually you're going to do quite a lot in groups. Mm-hmm. So Judith Herman is the psychiatrist who wrote a book about the triphasic approach for veterans and also for adult survivors of sexual abuse. So stabilization, trauma-focused therapy, and rehabilitation.
The three phases.
So when I got here, I inherited 87 beds. I was told it was really important to maintain a residential setting at that time. We didn't have community services at all. So I set up a 6-week rehabilitation program, which was really an offshoot of our RAF program, which had been borrowed by the Australians. I mentioned they had a big problem with their Vietnam veterans. They visited us in the early 90s and imported a lot of our ideas. And we set up primarily a residential treatment for the illest veterans. And we have various programs now. We're having anger management for people being in combat. We've got preparation for treatment programs, stabilization programs that use dialectic behavior therapy techniques. And then if you're really that ill, you might end up on a 6-week program as a resident. But if you're not that ill, you might end up now, we have cognitive processing therapy programs that you can run on Skype. So they're very manualized, or as individual trauma-focused therapy in the community as well.
So there's lots of different options depending on
the need. That's right.
Depending on the need. So is any veteran of the British Armed Forces eligible to come to combat stress?
Yes. To define a veteran, a British veteran is someone who served for 1 day in the military. Other countries define a veteran in a very different way. For them, it would be someone who's been deployed to an operational war zone, or else who's been deployed to a humanitarian operation. Whereas we are, in Britain, very inclusive. And to a degree, that's reasonable because we do see veterans who have been traumatized through military training accidents, which in other countries, they wouldn't be entitled to any treatment. So we have multidisciplinary teams. We have psychiatrists. I have about 5.5 full-time equivalent psychiatrists. We've got just under 30 occupational therapists, about 40 therapy and psychology staff, and then a collection of nurses, community psychiatric nurses, addictions nurses in the community. We've done a lot of needs studies. I established a research department in 2014 that's linked to the King Center for Military Health Research. We've published a lot of papers, something like 50 papers in 5 years. And so we know the need. So the veterans who present to us, increasingly they're younger, they're coming from the eras of Iraq and Afghanistan. They present with chronic PTSD, depression, and alcohol problems, past and present, with a social slide, lack of support with their family, and maybe half of them at least are unemployed. And they come to us through our helpline. So there's a 24/7 helpline. We get 17,000 calls a year, which is pretty big. They're then sent to a triage nurse on the phone. That would be a senior nurse who then reports to a multidisciplinary team in the region, and then people are allocated a treatment pathway. And we have maybe 3,000 veterans in our clinical service at any time. What's good now is other players are coming into the field. So the NHS has set up a transition and liaison service. As I mentioned before, people join the military perhaps because they have poor attachments in their primary family. So when people leave the military, if they have a mental health problem already, that can be a very difficult time. So transition out into a civilian world is difficult, can precipitate a mental health problem, or else, if you like, can uncover one. Because, many people in the military don't go sick. They drink alcohol instead. But of course, alcohol is more expensive in a civilian setting. So when you drink less, your PTSD emerges. So delayed presentations of PTSD and other mental illness are quite common in the first year to 18 months. This was studied by Professor Chris Bruin and his team. So this transition liaison service, in theory, covers the whole of England. So there should be one. All you do is Google TILS, and you should be able to get your veteran into an appropriate clinical service in the NHS or else in the third sector who work closely with TILS. And they also set up a complex treatment service, a CTS service for ongoing psychotherapy that can at least deliver even up to 64 sessions of outpatient treatment, which is quite a lot really now for the NHS. Yeah.
Do you think it's common for people to be attracted to the military because of having poor attachments to their family or their surrounding community?
Yeah, I think historically the military has always recruited from deprived areas. So it's joining the military is a big opportunity. And most people who join the military do extremely well. They normally come out with a trade. They normally come out with much better confidence, and usually, the vast majority, 80, 85% plus, maybe even 95%, adjust very well into a civilian life. But, some people don't. Our rates, we, if you like, are like the Royal Marsden for PTSD in veterans. And all our clinical audits from 2005 have shown that we get the same kind of population trying to access care. So that's people with, our figures for PTSD, something like 78% primary diagnosis of PTSD, with most of them with depression, most of them with alcohol problems, past and present. And many of them have poor attachment. So 52% of those would have had childhood problems, including either being adopted or else having physical, psychological or sexual abuse, or all of that combination. So childhood trauma is very common in our population. It's not to say it caused the problem. We tend not to be able to deliver long-term therapies for adult survivors of abuse. But, if the trauma is primarily military and it's reactivated some of the childhood trauma, we would treat that individual. Yeah.
So do you think an early life trauma in someone who subsequently goes on to serve in the military predisposes one to developing a PTSD-like condition?
Yes, I think, you are vulnerable if you've had a childhood trauma, but it doesn't mean you will get PTSD if you serve in an infantry regiment that goes into combat.
Yeah, not necessarily.
Yeah.
My understanding is you also did some work in forensics in terms of setting up a DBT service.
Yes, I was lucky enough to be appointed medical director for one of the private hospitals. That was Partnerships in Care at the time. I think now it's Elysium and the Priory, I think, who own the conglomeration of what was Partnerships in Care. But when I arrived, I found this was a women's hospital. There were many incidents, ligatures and all that, a lot of violence around. And I took over a ward that, as medical director of the hospital, that had a lot of trauma. The history of trauma was really kind of rampant. And so we needed to do trauma-focused work with these patients. I'd run a 90-day complex PTSD rehab program for about 7 years, 5, 6, 7 years before going to this job. And I used the 3 principles, so stabilization, using proper medications, psychoeducation, preparing you for therapy, and then trauma-focused therapy and rehabilitation, so trying to get you kind of functioning. But with these patients, we needed a DBT program. So we got trainers from Holland to train quite a lot of staff. I think the first tranche was 30 staff, and then many more were trained after that. And the rate of kind of incidents on my ward, I think I had about 10 patients. It dropped from something like, I don't know, quite a number to maybe 2 a month, which was quite a miracle, really.
Yeah. I wonder if you could explain a bit about the DBT model. So for those who don't know, DBT is dialectical behavior therapy, which is a therapy devised primarily to treat borderline personality disorder.
Yeah. I think DBT is a very interesting model, and it's been adapted as well in the post-traumatic stress disorder world to something called the STAIRS model. So what DBT is about is trying to control people's regulation of their emotions, so emotional regulation, trying to control the way they think and they feel, so their impulsivity and their relationships with themselves and other people. So essentially, there is a pre-contemplation kind of phase where people are encouraged to think whether or not they want to engage in DBT. And DBT is quite a big commitment because you have to attend, and I know I'm trained in DBT, I haven't practiced it for some time, but you have to attend classes at least once a week, and that's quite serious. And you have to be in contact with your therapist as well, and you give permission to your therapist who's working within a team to consult the team. And there are consequences. So it's primarily kind of aimed at reducing self-harm. It's aimed at controlling your emotions and getting you steady. It doesn't aim to treat your underlying trauma or anything like that. Now, people will say, look, people with borderline personality disorder don't have PTSD. Well,
it's becoming less clear.
I think it's less clear. I mean, I've hardly ever met somebody with a borderline personality disorder diagnosis who didn't have a very difficult experience or set of experiences, or were exposed to frank trauma in their childhood. So there's a huge overlap.
And there's an increasing school of thought that even other conditions such as psychosis or depression are linked to trauma of some kind. And you can almost start to think of them as trauma-like conditions.
Yes, I mean the main thing not to forget is, certainly when I trained, I had very good teachers in post-traumatic stress or trauma, the trauma world. Gordon Turnbull I've mentioned, John Rollins I've mentioned. I mean, I was taught that about 50% of your hospitalized psychiatric patient numbers had been traumatized in childhood, and commonly sexual abuse was fairly rife. So it's really important to take a proper history and to look for trauma. What we're not trained to do as junior psychiatrists, and certainly I wasn't trained other than when I was in the military, is to take a trauma history routinely. We don't do that. And I think if you're going to do psychotherapy, you definitely need to understand the atmosphere in the household, especially when people are growing up, not to insert any kind of false memories. We had all this false memory stuff in the 80s and early 90s, which I think deflected from the importance of taking a proper trauma history.
Definitely. Well, I'll start to wrap up because I'm conscious of your time, but I was wondering if there were any books you would recommend to someone who's either a psychiatrist, a psychologist, or even someone just interested in this sphere, books that have impacted your way of thinking.
What I think is really important is keeping your knowledge up in the literature. So my advice would be to join the traumatic stress kind of family, which is the International Society for Traumatic Stress Studies, or the ISTSS. This is based in America, but actually it's the World Forum for Trauma. There's something called the European Society for Traumatic Stress Studies, and that's the ESTSS. I mean, you could join that; it's cheaper, and you'll still get the journals. The Journal of Traumatic Stress has a lot of information. I think that's really, really important. Judith Herman's book is very important. That is 1992. I think it's called Trauma. She describes the phasic intervention for veterans and for adult survivors of abuse. Sandy Bloom wrote a book called Creating Sanctuary. There's a first version, then she's updated it with a second book. I think the first book is in the 90s. The more recent one is maybe a couple of years ago. That's worth reading as well, because that talks about treating trauma within a kind of a therapeutic environment. And that's what we have here at Combat Stress in our residential centers. We have expanded the community dramatically compared to what it was like when I joined. So we did that in 2010. We have a lot of clinicians now in the community. But the therapeutic environment is very important, as we all know, and really is very rare now in general psychiatry in this country to have beds, let alone a therapeutic environment.
Great. And lastly, I ask lots of annoying questions, so I always give my guests the opportunity to ask me a question at the end of the interview.
Okay, so look, why have you come to interview me in relation to military trauma? Are people really interested these days, do you think?
I can't imagine that someone would be in this sphere and not be interested, because obviously serving in the military is such an extreme experience which most people are very sheltered from. I think increasingly in modern society, people are becoming more and more protected from danger, from real threats, but also from like the real kind of connection you can get in the military, the real kind of experience of solidarity with sort of a soldier by your side, as you mentioned. One word you could use to describe being a soldier or being in combat, it's kind of like hyper-reality. And what we're doing a lot of the time at home is we're really shielding ourselves from reality a lot of the time. And so to get an idea of what these kinds of people are experiencing, and the very, like you said, it can be traumatic, but it can also be an intense vehicle for growth.
Yes.
These kinds of experiences, and can give you a real perspective on life. I think it's important for people to hear about, and I think they would definitely be interested.
Yeah, I agree. Can I just say one final anecdote? I mean, I have recommended, when I gave evidence to the Defence Select Committee last April 18, that every single college introduces one question on military health, so that our up-and-coming students, particularly psychiatrists, I think, have a small book to read on military psychiatry. And we are a dying breed. We're in a phase now where people have forgotten the impact of war. But of course, people like me are picking up the pieces. The NHS now has set up some services, and it's really important to try and spot these people who need help.
Excellent. Okay, great. So Dr. Walter Busuttil from Combat Stress, would you like to talk about your website?
Yes, we have a website. So go on to our Combat Stress website. I guess it's www.combatstress.org.uk. We have a helpline number there. You can refer online as well. And there's a lot of information. If you click on the research page, we've published something like 50 plus papers in the last 5 years. I think 21 in the last year. So it's quite dramatic, and there's a lot to read and a lot to learn.
Great. Thank you very much.
Thank you.
You are listening to the Thinking Mind podcast.
If you enjoyed today's podcast, we'd love it if you share it with a friend, or you could give us a rating on Apple Podcasts, Spotify, or wherever you listen. If you fancy it, you can even buy us a coffee to support the team, and the links for that will be in the show notes. Thanks for listening.